Alrighty, we are live here. So I am running the show tonight, so hopefully we do not have many technical issues. Torn is on vacation, so he was at Niagara Falls today. Sent a picture out, so Torn, hope you are having fun. But this week, it's the four of us here, and we are talking about headaches, jaw pain, and kind of how and why we integrate with dentists. So we'll give it just a couple more minutes because I know it just hit 5:30. But if you want to comment, who you are, where you're from, what are you drinking? What are you drinking tonight? What do you got?
What am I drinking? I'm drinking a little whiskey called Old Emery.
All right, Jason.
Voodoo Ranger.
Lori's got her buble.
Yep, a sparkling water.
And what do you have?
I have Di Serrano and Sprite.
All right.
So, but yeah, again, this is what I think episode 5
4 or 5. Yeah.
that we've done. So, kind of for this week, Jason's kind of become the TMJ guy. So he's kind of taking a little bit of the lead, talking a little bit about anatomy and different things of that sort. So I'm going to let you just kind of start diving on in. A little bit of where you want to start. If you have questions, comments, please throw them in the chat and whatnot. We'll be watching it to help answer questions. But this is recorded, so people can watch it later. And if you have other questions later on, send a message, leave a comment, and we will see it so we can address it.
Okay, thank you. When I started working here at the Husker Clinic, it's been over 25 years ago, Ron really had a knack for TMJ. We would get a lot of TMJ patients, and he would say, well, go do this, go do that. I had no idea really what I was doing at the time because I was right out of school, and you get kind of, I don't want to say scared, but you get overwhelmed with the jaw because it has to do with the head. Well, as I've learned over many, many years, it's no different than any other joint we see. Today I saw 3 TMJ patients, in one that was one of Ron's former patients to a newly acute hot right off the coals, and another one, and a teenager that was just out of orthodontist. So 3 different types of patients. And the thing is, the one gal, one of Ron's patients, she has an artificial joint in her jaw. So she's had probably 7 to 8 surgeries. I don't know. The other gal didn't have anything really kind of set it off, but there's other influences that I've learned over the course of years, and that's what we're going to talk about today. It's not just the jaw that you're looking at. You're looking at the neck. You're looking at the rib cage orientation. You're looking at a lot of other things, tightness throughout the chest wall. So I'm going to kind of go through some things, and Ann's going to kind of stream through some things. But if you think of, from a PRI perspective, we're always taught the neck and the mandible go hand in hand. So you can't disassociate the mandible from the cervical spine. And I always tell people, think of a bowling ball sitting on a stick, or if you want to call it a spaghetti noodle, some people call it a spaghetti noodle. You got to keep this occiput. Okay, this is just your skull here. If I took this head and put this here like this, I don't know if I can get that in there. That's what we got, okay? But this doesn't have the whole skull on it. So your head is sitting on a pole, okay? And your mandible influences your neck, and your neck influences your mandible. So what I refer to is these 2 joints back here, where your occiput sits on your very top cervical vertebrae, is your OA joint, or what we call the occipital atlantal joint. Your atlas is your first cervical vertebrae, and your occipital bone is your occiput, okay? I refer to it as you have 3 legs of a stool, okay? You have 2 legs in the back, which are your 2 OA joints. You have 1 and 2, okay, which are right here. You have 1 here and 1 here. And then in the front, you have your teeth, or I don't know if they can see how they can see that.
Yep.
You have your teeth, and how your teeth come into occlusion. Okay, all 3 of those, okay, are influenced by each other. So I tell people, if you were to take one of those legs and you were to just take a saw and you were to cut one of those legs off, okay, that stool, okay, is not going to sit level. okay? So you're gonna ultimately figure out a way to balance out that stool. You might lean one way, you might sit differently, but you can alter your occlusion to help stabilize the neck. Likewise, you can change your neck position to alter your occlusion. So you got to kind of take all three in combination. So what we're trying to do, there's some people that may come in, like today, I had somebody that had a really acute stage of TMD. Sometimes people are off their disc. We're going to draw these pictures up, but these were all referrals from dentists, believe it or not. One was an orthodontist, one was a general dentist. And they referred them over because they know from a dental perspective, they can only do what they can do, and they need other help. So the integration between the two people is imperative, just because you got to communicate. So they've already talked about maybe potentially taking an impression for a splint, which we'll get into later, but a lot of times we don't have to jump to that conclusion right away to kind of let things settle down, because oftentimes people can't even open up their mouth to get the impressions made from the get-go. So so the thing is with the back to the three legs of the stool, you have to balance that out. So sometimes people will literally tell you that their teeth do not line up, or when they bite down, they don't feel like their teeth hit equally. So right there, it tells you they may have truly a dental occlusion problem, or they might have a cervical problem. If you were to ask a dentist would basically say, potentially, not all, okay, depends on who you're talking to, may say that that's a dental malocclusion, okay? Well, I can tell you from the flip side, I can change their occlusion by changing their neck position, okay? So what I would want to do is I want to make sure that neck position, before there's any calibration of any splint, any calibration of any dental occlusion, you want to make sure that neck is neutral, which we would incorporate 30 degrees of cervical lordosis. You want to have, a good clean cervical rotation and side bending bilaterally on both sides of the spine. Oftentimes people will take a splint, okay, and I always tell people, if you did the calibration of the splint and your neck's not in the right position, you don't know how that's going to change your occlusion. Trying to think of, I lost my train of thought here. So the way I look at it too, and outside of just like the head, neck, and jaw, is think of your body, okay, being a door frame on a door, okay? So think of the structure of the door frame, okay? If you think of the door being the jaw, okay? If the door doesn't open, okay, what would a typical person do to the door?
Push on it.
Push on it, but if it doesn't open, what would you do?
They might
You're gonna
saw it
shim
off.
it.
They might
Shim
you're gonna
it,
shim it, or
yeah.
you're gonna shave the door down, okay? So you shave the door down, and lo and behold, the door opens. You got good opening of the door, okay? 6 months goes down the road. You go up to get the Christmas tree out of the closet. The door won't open, okay? So what do? You shim the door down, okay? I've seen it where people, and I'm not saying it's all the cases, but there's a lot of times where people, dentists or other people, they don't know any better, they'll start shimming teeth down, okay? But what we're trying to emphasize is that sometimes is the case, but not always the case. But if you shim that, or if you shave that door down, it may not be the door that's the problem. It could be the door frame that's crooked. That might be the reason why you have to shim that or shave that door down. So we're looking at other things, just that other than the door. We're looking at other influences. Just like today, this gal that I saw, it wasn't her. She had a lot of facial pain, but just by merely pushing her rib cage down, it took a lot of her tension out of her neck. It took the tension out of her face. It sometimes people describe it as like someone's just pouring hot water or cold water over their face. It just took all the tension out of her head. And then there's other times that people get it into a closed lock position. And that's when we have a discal issue that we're influenced by the position of the jaw position. So I'm going to draw this out. I don't know if anybody can see this.
Draw it and we'll move it closer.
So this will kind of influence why people have various issues. Some people will, obviously they go see the dentist. They may come in. The dentist will send them over. They don't really. It could be one of 3 or 4 things. 3 common things that people send patients over for is ear pain. Okay, would be number one. They go to an ENT doctor. The ENT doctor checks them out. They said there's nothing wrong with their ear. Okay. Number 2, they may truly have an acute episode where they can't open their mouth, and that was what I'm going to draw out here. So they have an acute episode, and everybody always wants to know why we do this. They call it magic, but it's really not magic, because if you understand the mechanics of what the jaw does, it's really simple to do, and it's very rewarding because you help those people. You don't realize how much your jaw is utilized in a day. You talk, you drink, you swallow, you do lots of things. I mean, think of how many times you open and close your mouth in a day. And then now on top of it, you have a bummed up jaw, and now you're forced to use it, okay? And these jaw things don't necessarily go away right away. They'll go away, but you just don't want to aggravate it by doing things that you shouldn't be doing. So I'm going to draw this out, and I don't know if you guys can, I'm going to kind of, don't make fun of my artistry. You like that? So
There's a little bit of a.
Yeah. Draw it first, and then we gotta move
I'll make it,
move it a little bit. So
I'll make it thicker.
it's just sort of touching the light a little bit.
Is that better?
Yeah.
That looks good.
So if you look at this ear is probably too close to the jaw, okay? But your mandible, okay, is this bone here, okay? And this is your skull. And in between your mandible and your skull, you have a disc, okay? And I don't have a picture of that, but there's basically, if you look at this skull here, okay, we're looking at this right here, okay, where there's a little disc.
Can you hold it, look at yourself in the
Nope,
camera?
go
Actually,
get close
face
to
the camera, there you
There
go.
we go. So it'd be this joint right here, right where my middle finger's at, that it opens and closes your jaw. Okay, but there's a little piece of cartilage, no different than a piece of cartilage in between your knee, in between your vertebrae. It's like a shock absorber. Okay, so when you open your mouth, this jaw is going to go down like this.
Slide out of the way. There
It's
you go.
going to go down like this. This here is going to translate with this. And this disc here, I don't know if you can see this, I'm going to color it here, has always got to follow that bone. Okay? So as you open your mouth, this disc is going to go forward like this. Okay? If you were to, that thing's like a little pumpkin seed or a watermelon seed. So a lot of times if you're what we call, if you're on your disc or if you are off your disc, I'm going to show you an example of when you're off your disc. I'm going to call it a disc derangement with reduction, and then a disc derangement without reduction. So a disc derangement would be when this disc, when you open up, and it's there.
So it goes forward.
Goes forward. Okay, so the reason why you can't open your mouth is because that disc is forward. Okay, so the simple mechanics of it is you might have somebody that's on one side. Typically it's on one side. Sometimes you get it on both sides, but very rarely do you have it on both sides. It's usually one side that's the culprit. So I equate it to, like I was telling these people today, it's almost like a sliding closet door. Okay, well, so if you open a sliding closet door and it's got the little tracks on it, you open the door and all of a sudden it gets stuck. Okay, you have two choices. Either one, you're going to give it a nudge. You're going to give it a nudge and the door is going to open. Okay, and it's going to open all the way. Number two, you give it a nudge and it doesn't move. So you give it an even bigger nudge, and guess what happens? The door falls off the tracks. Now you have a problem. You can't open the door. The door is not going to open. So this would be the door off the tracks. Oftentimes what you can do is if I took this thing back, then I put this more like kind of in here, maybe a little bit more forward, but not quite all the way forward. what you're gonna do is you're gonna hear it click. So a lot of times people complain of clicking, or they'll complain of popping in their ear. They'll complain of ringing in their ear. They'll pretend like they're always pulling on there. They got water in their ear, whatever it may be, fullness. What happens is what you're doing is you're still tracking on that door, but that disc is a little bit forward. So when you hear that click, what happens is you're actually, it's not the full big nudge. You're giving a nudge to still open. So you get on that track and you can open your mouth. Okay. But back to the ear pain or the fullness in the ear. The reason why people have fullness in their ear, okay, is there's a muscle that attaches to this disc. It's called the superior head of your lateral pterygoid. Okay. And it goes to some of the bones in your ear. Okay. And there's some other real small muscles called your tensor valli palatini, and there's all these really small muscles that are important, but because they are important. But a lot of times people will go to their ENT docs and they'll say, well, I got ear pain, but they look and they don't have an ear infection, they don't have a sinus infection, they don't have anything wrong with their ear. But the reason why they're having ear pain is if this disc is going forward and it's not totally off, but that here, every time you open and close, okay, what you're going to do is you're going to put tissue, you're going to put irritation on that tissue here. And so they call that retrodiscal tissue irritation. So a lot of times we can do things as a therapist to get the alignment or things in a better position for them to track correctly. From a dental perspective, sometimes they'll want to do a dental appliance. And so what I would do is I'd put your teeth here, your upper teeth here. And what they would do is they put a hard piece of acrylic plastic here in between your teeth. What's going to do is it's going to basically distract this joint to get you back on that disc, to take that disc to pull back, to take the pressure off of your disc. So what they would look like, we got different, like a piece of, it would look something like this. And you can get over the counter, or yeah, she's got one on it would look something like this, a piece of plastic that you basically go over to the dental office, or dental office would actually make one. Okay, but what we would want to make sure before we do this dental appliance, we want to make sure the neck is in a better position or in an optimal position, because we're looking at that door frame versus just the door. So the door is kind of like the teeth in the jaw joint. Okay, they're all one. You're what they use the term centric occlusion is ideal occlusion, and centric relation is ideal position of that bone in that socket. Well, they all have, in an ideal world, they all three have to be in the same ideal position, but they're not always in the same position, because I believe, or we would probably all agree, that your neck has an influence on those three positions. I don't know if you guys want to comment on anything, or if
Well, I think you made a couple of good points earlier. It's just how the other parts of your body, the neck and the rib cage, and the way we breathe and our pecs all have an influence on how we're going to move, not only from down below, but up above as well. So often when I see a patient that'll come in with a jaw issue or headaches or something like that, I frequently see issues where they've got a tight left pec, or they can't breathe well, can't inhale on the right side. Well, that's all going to have an influence on the position that your neck is in. And I always tell people, I think of the neck and the jaw as one entity and the cranium as another entity. And if those two entities aren't working together, now you've got those joints here that are not working as a team. One's trying to go one way and the other one's not trying to work with it as a team. So you've got to take all those things into consideration. I think the other thing too that you've talked about, like with the dental appliance, is when we work with our patients, and Dr. Megan and Dr. Hole, a dentist and an orthodontist that we do a lot of work with, we like to be involved in the process to make sure that not only is the dentist getting what they want with how the teeth are occluding or coming together with that appliance, but that the rest of the body is doing what needs to too. Because if you fail to include that part, none of this other is going to work to do what we're after.
I think it's also important to note that some of your neck muscles attach from your jaw and go down and attach to your cervical vertebrae. So if your neck gets out of position, that's also going to influence your jaw position. That could also affect your TMJ position. So it's all interrelated. And the second point is, we like dental appliances that go on the bottom teeth,
Yeah.
not the top teeth. I think that's important to note. The image you put up there was more for a maxillary or top teeth splint. So I just want to make sure we clarify that it's a bottom splint. We typically like appliances that cover all of the bottom teeth, but there are some circumstances that we would put an MMOO in somebody. And sometimes that can depend on the tongue, to allow room for the tongue. If people are having a hard time delineating between left and right, that makes it a little bit easier. If they're in an occupation where they have to talk a lot, I will tend to get that so they can wear it more often, because the one that covers all the front teeth, it'll make them talk differently or be hard to talk without a lisp. So I hope that answers.
We had a question come in. From Cameron, in what circumstances would you choose to use a dental appliance without anterior canine guidance?
So yeah,
So
that's what we were talking about. So though, for everyone else, that's when it doesn't cover all the front 4 bottom teeth.
Yep.
So anyway.
The other thing Dave kind of alluded to it, I always kind of like explain, and Ron wrote an article on this years ago. I think it was in the dental clinics in North America, and it was on thoracoabdominal strength and its influence on temporomandibular joint dysfunction. I don't know if you guys know what I'm talking about. We're just doing reverse curl downs, but it had nothing to do with TMJ. It did, but really, I mean, back then this was probably written in probably like 1996, 1997. I don't know when it was written, but the biggest thing, what I try to teach my patients from a TMD perspective, or somebody that has jaw pain, and most dentists will agree with this, is you're going to try to bring your jaw forward, not all the time, but you're going to try to bring your lower jaw forward to kind of get you back on that disc. If your head goes forward, or if your jaw goes forward, that means your head's got to go back. So as a therapist, I'm trying to figure out ways to get my head back so my mandible can go forward. Okay, so Dave alluded to this. One way, if your head's forward and you have a forward head posture, okay, your pecs are tight. So what we're going to try to do is we're going to try to stretch these pecs out to get your head back. Okay, we might have you do a wall squat where we're going to have you get down in a squatting position to get your head to go back, because you're not going to fall forward when you're in a squat. So what I kind of explain to patients, if you think of strings on a body, okay, you have a string that goes from your pubic bone to your sternum, okay, and that string is long, okay, because as your pelvis goes forward, your ribs go up, okay. Well, now you're not going to walk like a drum major, so you got to figure out how to get your head that's now kind of back behind your pelvis, back over your pelvis. So what you're going to do is you're going to take your shoulders and you're going to round them out. Now, granted, this here is still staying up, but now everything is going forward, okay? Now, this string here is tight, and now you got a string that goes from your sternum to your Adam's apple. There's a bone in your throat called your hyoid bone. That muscle's now tight. And then not only that, you're going to bring your head back, and the muscle that goes from your hyoid bone or your Adam's apple to your mandible is tight. So if you just push down on the rib cage, this is what I'm referring to with Ron's article. He talked about how he could influence temporomandibular joint dysfunction by rib cage mechanics. If you push on this down here, this tightens this string, and it increases the length of these strings up here, which gets your head to go back. So you can work on your jaw and do all these things with your jaw, and you might get some relief. But if you don't look at the foundation down below, and you're not working on the things down below, I learned this long ago, that you're not just working on a jaw joint, you're working on some things down below to kind of help influence the position, because they'll get better, but they'll be back in your office in a week or two or a month, because they're just looking at the joint.
Yeah.
So that's why it always, Dave alluded to it, you got to look at the whole picture as far as the pelvis, thoracoabdominal strength, chest wall flexibility, and how that bowling ball is sitting on that broomstick. And how it's going to, and your mandible might be trying to stabilize you to kind of keep you on that broomstick, because you're trying to hold your neck. You're using your teeth to save your neck, or sometimes people use their neck to alter their teeth. So
a lot of times, with our, let's say, local patients, like, it's not the first thing is we go to the dentist. Like
Yes.
there are other things that we can work on first
Correct.
Yep.
to see if that helps them out first. Can they get back to their normal positioning, all that type of stuff, then hey, life is good. So don't be thinking, you know, oh, I have jaw pain. Oop, I gotta go get an appliance, go
Well, and
talk to
that's
my
just like
dentist, all
told a
that
couple of
type
my
of
patients
stuff.
today is, that, you know, because the dentist already took impressions, I said, you may not need that dental appliance. Let's see how things go. You might need it. You know, I think the biggest thing that I probably, when I see a jaw patient, is if they're starting to do better, we'll see how they do. If they have a reoccurrence and they're back in my office in like a month or two, they're probably a clincher or they're doing something that they shouldn't be doing, and they need some kind of a nighttime appliance because they're clinching it out at night, which is pulling them off that disc or causing their jaw pain. There's other purpose. I'm just talking strictly TMD. I'm not talking about what we see other patients for.
Yep.
Because we use splints for other
Lots of
purposes
other things.
for a sensory integrative approach. But when people truly have a jaw problem, the instantaneous thing is get them in a splint, get them, some even go to an oral surgeon, which is fine. But they want to take an impression to get them a splint. Well, I try to get everything else settled down. The other thing that I'd like to allude to, and Lori can probably even allude on this too, there's different kinds of oral appliances or what we call oral orthotics. One's more of a full occlusal orthotic. A lot of times we haven't really talked about headaches, but we're going to talk about headaches now. It's called an NTI appliance. And that's called a nociceptive trigeminal inhibitor. Okay. You know that?
Yeah, I do.
NTI.
So what
We'll keep it
that?
at that.
So I haven't seen one in a while.
That's the splint, you guys, that covers like,
Just the
it
front two
only
teeth.
covers your front teeth, like your bottom and top teeth. So it'd be an appliance that goes from your front teeth like out to the side, but it wouldn't cover your side or back teeth. And you want to give people headaches, get them an NTI splint.
Well,
That's my opinion.
and this is your points well viewed.
Yeah.
But the thing is, an NTI is not a permanent appliance. It will help with people that have acute headaches initially, but that would not be a long-term splint you'd want to put somebody in. So just an example, if you guys want to try this, I don't know if you guys want to try this, but you can take that pen, Dave. I've not even told Dave what to do. But if you guys all put your hands on your temporal bones or just above your ears and you just bite down, you should feel those muscles kind of come into your fingertips. So if you bite down, do you feel that?
Mhm.
Okay. Now, Dave, I want you to put that pen in. No, I want to go horizontal. Put that in your mouth.
Okay.
Yep. And I'll bite down.
Oh yeah, I lost it.
So the purpose of that is to try to shut down your temporalis muscle, which is an elevator of your mouth or of your jaw. And that's what times people, when they have temporal headaches, they put that slit in their mouth, which will take their headache away.
For a
But
while.
from a long-term perspective, and this is what Lori's alluding to, it can create other malocclusion problems where you might have dental malocclusion in the back because now your teeth aren't hitting in the back. And so now guess what? Your neck, remember those three parts of that stool. Now your neck's going to make up for what you're not hitting from a dental perspective. And that's why I always kind of like to use those three things is how one influences the other. So you might take care of a headache problem temporarily or a jaw problem temporarily, but now guess what you created? You created a neck problem.
Because if you think about it, you guys, if you think about a wheelbarrow,
Yeah. Well,
and
there
if
you
you
go.
put all the weight on the front of the wheelbarrow, that's going to cause your neck to go straight.
Yep.
And if your neck goes straight, now you can create headaches from a different, because now your neck is in the correct biomechanical position. Or if you have an anterior open bite, meaning your front teeth don't hit and you're only feeling your back teeth, that could also create neck tension.
And Jason's famous for always telling people we have two sets of floors, the one under our feet and the one where our molars come together. And you take that away, you've lost your grounding.
Mhm. And that's a whole nother ball of wax. But as far as dentists, I would tell for practitioners or even for patients out there, clicking, when people have clicking in their jaw, I don't really panic. If they have clicking and pain, then that's a little bit more concerned because they're having, that door's not tracking right. But there's a lot of people that have clicking in their jaw. And if you look at research, there's probably, you could have people that have had jaw pain or not jaw pain, but they have jaw issues for 20 plus years, and they could do some crazy thing and it's just like a back spasm. They could bend over, pick up a pencil, and they could bite on a popcorn hole and it throws their jaw out of whack. But as long as they're not having pain, it's just how that alignment. So what we're trying to do is we're trying to look at alignment. I would not panic with a lot of clicking. You know, like I had a gentleman today, it literally sounds like a broken dry stick that's cracking, but he really didn't have any pain. But it's annoying. But I think part of it goes back to from his standpoint, and this is where he had a deep class 2 bite. So what they were trying to do is they were trying to bring his jaw forward, okay, but they were using rubber bands. So he was fine when he was in orthodontia. As soon as he got out of orthodontia, things were starting to shift. So that rubber band went back to what, the rubber bands that the orthodontist was putting on them helped get his teeth all nice and straight. But again, it's a centric occlusion versus the centric relation of the jaw. So the centric relation and centric occlusion weren't matching up. And so he was not in the right position. So as soon as he got out of orthodontia, he had a little bit of a jaw problem, but it's not, you see a lot of that. But he didn't really have pain. So, my job is to try to get better mechanics across the neck and the jaw joints.
So talking about, just to help summarize, you would look at a splint for some of a TMJ to help to decompress the jaw, to put the jaw in a good position with the disc.
Correct.
Yes.
If we're looking at headaches, in my humble opinion, I am going to be using a splint to help out with the neck position, and to help inhibit a neck, because if the neck is in the right position, neck muscles are going to be overworking.
Mm-hmm.
So we're going to put someone in a splint to help get the neck in the correct biomechanical position and strengthen below that neck and the pelvis and the thorax or your trunk to help get this to turn on and stabilize you, versus some people will over stabilize with their bite or with their neck position. And you really see that a lot with whiplash injuries.
Mm-hmm.
People that have been in car accidents, because then now they're going to clench.
3 legs of the pole.
They'll over clench. And to get that stability, because they're unstable at their 2 leg joints back here at the back of your skull that Jason talked about.
So,
I mean, but truthfully, that's classic me.
Yeah.
If you really want to think about it, like when I came in the last time as a prime patient, my headache was here. Didn't matter what we did, like before I could actually get here, and I needed that dental appliance. My jaw clicks and pops all the time.
but you have no problems.
No problems.
Yeah.
Like so don't go chasing things.
Something, yes.
Right.
Because it spins, it pops, it does all this stuff, but there's no pain. So just making sure that people understand that. Like, you can notice somebody has a click, don't worry about it.
You're not diagnosed with
it's yeah. So you got to keep it simple. But I think with one of the big things, we were talking this morning, when people are getting an appliance or the impressions done, the position of the neck matters. Like, if you don't have that, it's game over. Like, so, as practitioners are looking at that, if you're a patient watching this, and you're saying, yes, I have, jaw issues, TMD, all that type of stuff, like, you got to find somebody who actually understands that. Otherwise, you could just be spending money and wasting money, and you're not going to necessarily feel better.
And so what we do at the clinic is we will go out to the dentist office with our patients to make sure the neck is in the correct biomechanical position when they take the bite and the bite registration. And then when our patients get the delivery of that appliance, we're going to be working with that dentist to say, calibrate the splint. We're going to make sure that neck is in a good biomechanical position as well.
And I think that's one of the things that sets us apart from so many other clinicians that we were just talking about it earlier today at our staff meeting, how there are a lot of really good therapists out there who are trying to integrate with a dentist, but very few of those clinicians actually ever go to the dentist's office during the delivery and calibration, and the patient ends up with a really good appliance, but it's never been actually properly calibrated for them to be in a neutral position.
I think it's also important to note that the goal isn't to be in a splint long term during the day, because initially we'll have our patients wear it during the day with their physical therapy activity. Obviously, you would take it out to eat, but the goal would be to be able to be off of it during the day. That patients are able to hold that neutral position at their neck and their body, and then they might need the splint indefinitely at night. Sometimes the patients cannot wean off of that splint during the day and keep their neck in a neutral position. They have a malocclusion with their bite. That may be a consideration for orthodontia if they don't want to wear a splint long term. But you'd have to really wear a splint like 24 hours a day for decades in order for it to really change your bite. Yeah. But sometimes I've had some of my bites change when they get their neck and they get their body in a neutral position, and their bite hits differently because their door frame is now straight and it changes their bite. So it's not that the splint caused the bite to change, it's that they got their body in a good neutral position. Yeah. And caused their bite to be different.
Yes, it does. Any questions out there from Zoom, YouTube world? Anything out there that you guys have questions on? You know, all right, let's go this route. Jason, how long would you typically, because I know people ask this, how long is it going to take you to feel better for jaw pain, TMD issues? You hear that all the time. How many times are we going to have to come here? Well, what would you say is a typical
It just depends
response?
on the acuteness of the patient. So this one patient that, like I said, was hot off the coals.
Mhm.
I'm going to see her Friday. So I saw her today, which is Wednesday. I'm going to see her Friday. The other patient, the teenager that I saw, I'm not going to see him for about 10 days, 2 weeks, because he has really no pain, but I'm going to try to, I mean, he's got all the tools that I provided him with necessary to do this. The other, we got to get the inflammation down on this other gal. The other gal is just a long-term chronic jaw patient. So I always tell people, it's not going to go away tomorrow, but you should know relatively quick, as long as you know what to do and how, and if you're doing it right, it should not cause you more grief. So I would tell you, typically in an acute phase, if they come in and they have limited motion, when I say they can't open their mouth, you should have about 45 millimeters, or a simple test is you should be able to have 3 finger breaths vertically go into your mouth. If you can't get 3 fingers in your mouth, then you probably have some kind of a jaw issue. So what we're looking at is, number one, is there pain down? Number one, it's like with anything else in any kind of rehab. Number one, control pain and swelling. Number 2 is range of motion. Number 3 is strength. Last but not least is functional activity. So if you can't control pain and swelling, you're not past pain and swelling, you can't go to range of motion, and you can't go to strength, and you can't go to functional activity. So we got to calm things down. Sometimes you might have to talk to the dentist. They might, or their primary care physician, get them on a muscle relaxer, shut their neck off, or an anti-inflammatory to just kind of get things settled down. But we're not just looking at mechanics. We, as therapists, we might do some ultrasound, like I did some ultrasound on this patient today, and they felt pretty good afterwards. But the big thing is knowing why you're here. Just the mere fact of putting him in a cervical pillow took her tension down. Getting a rib cage pushed down helped her. So there's things that we're trying to find things to help these individuals cope with this, because it's not going to go away. Like I said, you think of how many times you open your mouth in a day. It's like a blister. It's like a blister. You rub a blister more and more and more, that it's just going to get irritated. It's not going to fill up with fluid, but you just want to make sure you're not always irritated. So soft food diet, like the dentist told them. Here's another key thing too. Foods to avoid with jaw: celery, carrots, tortilla chips, nuts, peanut brittle, and popcorn.
Who eats peanut brittle?
Well, you'd be surprised.
Maybe not right now, but come on.
But back, I'd get a patient or two back around Christmas. They'd bite into peanut brittle, they'd bite into it, or they'd bite into those. They don't make them anymore. You probably don't. You're too young. The rope candies. You know what I'm talking about? The ones that were like the rope.
Oh, I know you're talking about the individual pieces of candy on the rope. The rope necklaces when we were a kid had the little pieces of candy.
Oh,
You know what I'm talking about?
yeah, but
Yeah.
I don't remember what those.
I don't
are
think they
called.
make those anymore.
There's a
They-
Christmas candy.
But
I got nothing.
I do think something that's important, because a lot of times even dentists just look at the TMJ. A lot of people aren't looking at the relationship between the TMJ and the neck.
Yep.
And I think that would probably be the most important thing to
Stakeholders.
highlight
Yes,
is neck
Mhm.
and TMJ.
yes, yes. So we got a question that came through. If someone's cranium was locked up, example, right torsion, and the occlusion itself was the catalyst, is there a scenario where you couldn't get the patient neutral during bite impressions?
We've had people with left side bending and
Yeah.
right torsion.
Yeah,
And so sometimes, I know you guys have done the right TMCC manual technique.
Mhm.
Sometimes it's placing their neck in a cervical pillow.
Yep.
Sometimes it might be positioning the jaw, but we will position them when they're doing the bite registration. And then they leave the bite registration in and walk up and down the hallway, and we've gotten them neutral.
Yeah.
Sometimes we might have to use glasses, because the glasses can also influence the neck, and they have the right footwear. So those might be tools that we're having to use to help get the patient neutral, even though the occlusion is a catalyst to help out too.
And I would even flip the coin around on this, is when you say, you say the occlusion is the catalyst. When you say the occlusion is the catalyst, why you say the occlusion is the catalyst? Because I could flip the coin around and say that the cranium is the catalyst. So you really don't know. I mean, you got to have all those things, and some people believe that the cranial bones don't even move. But your teeth, when you say that the occlusion is the catalyst, your teeth will go anywhere your bones go. So it's not, they're kind of like the bus riders on the bus. They're going to go wherever that bus goes. Well,
you got all the analogies tonight. I like it. I like it.
so you would want to make sure, like they said, you want to make sure the neck is close, or what you would feel is neutral, or you would. And I'll just throw this out at you right now. And I'll just do this to all you guys. If you take, I can change your occlusion or alter your occlusion, whichever you want to change, whatever you want to say, however you want to say it, by the position of your neck, and so I'm just going to run you through this, and not everybody's going to be the same. This is just for normal occlusal and cervical dynamics. If everybody was just to look up towards the ceiling and you bite down with your teeth, which teeth, for these three people in the room, which teeth do you feel hit first? If you look way up towards the ceiling.
My back teeth.
Back teeth.
Yep.
Okay. If you look down towards the floor, you should feel a different set of teeth hit.
Front teeth.
Front teeth. Okay. Now here's where it gets tricky. And this is kind of what he's talking about from a cranial torsion. Okay. If I took your head and I went back and I went over to the right and the side bended your head to the right. So you look to the left and side bend to the right. Which teeth do you feel?
I felt my right
I was
teeth.
gonna say, I think I feel my right. I don't know.
Right,
the
but
bite.
back teeth.
Yeah.
So if you look
Right.
up, look to the left and side bend to the right, the only
Right
teeth,
teeth.
the only teeth you should feel is your right teeth. Likewise, if you look up and rotate your head to the right and side bend left,
Feel your
Now,
left
do
teeth.
you only feel, because, and I know it's probably my bite, which does not cause me problems, but if I do this and rotate,
so the side that your side.
I definitely know that the right
So the
side is
side that your
contacting
side
first,
bending-
but I can get both the
Yes,
contact.
yes.
Okay.
But if you can't do that, you're normal.
Okay.
If you can't,
Relatively.
but that's just a normal.
It's Dave.
That's just a normal cranial occlusal mechanical thing. So if you're doing that and somebody can't, like his instance about a cranial torsion, if they can't do that,
Ooh. Sorry, guys.
Can you guys hear us?
camera go dead. It's going, it says 44.
Yeah, we're
The
just
time's still
frozen.
running, but it's not
Um,
showing updated.
I'm stuck in a,
You look like Barbie.
Can you guys message if you can still hear us right now? Can somebody send something through?
okay,
All right,
We
we're
can
gonna
hear
keep talking. It looks like our battery died, even though I changed it out. So sorry about that, guys. So go ahead, just keep talking.
so,
You're on.
Yeah,
so
they
we'll
can still
answer
hear
a
us.
question. They would love to hear about the Haruska Clinic's oral appliance and when and how it should be used.
And which one are you referring to?
Well, they probably want to know anything that we use, so the MOO or the MMOO.
Or the, yeah.
So we have two different types of appliances that we talked about earlier. We have the MOO that covers all of the bottom teeth, and then we have the MMOO. And that covers just the side and back
Few
teeth.
molars.
And we use appliances to help get the neck in a neutral position, to help to inhibit the neck, to assist the neck, trunk, and pelvis to integrate and work together. So we would typically, if someone needs an appliance for their physical therapy treatment, whether it be for headaches, whether it be for TMJ, we're going to utilize that appliance and have them wear it during the day. And with their physical therapy activity, they're going to take it out when they eat, and they're going to wear it at night, with the goal over time is that you would be able to wean off of that appliance during the day and still be able to keep the neck, the trunk, and the pelvis in a neutral position, with people probably having to wear it indefinitely at night. So I hope, Bella PT, that answered your question. The goal is the appliance is used to help to inhibit a neck, to assist with neutral positioning of range of motion of the neck, the trunk, and the pelvis to be in a neutral state. And then you want to retrain the body how to be stable and
On somebody, if we're doing all the right stuff and you can't get cervical axial rotation bilateral, you can't get cervical lateral flexion, or even if there's other parts of the body, you can't get the brachial chain or the lumbopelvic region to clear up, and you've done all the right stuff, and we go to a point where we maybe disocclude a person and see that there's a change in how their body functions, that's an indicator that the bite is having an influence on you, and that's when we might utilize an appliance to help get them neutral, again, with us being directly involved with the dentist to make sure the calibration process allows for all the proper contact and inhibition.
And I think it kind of goes back, like Lori was saying, I tell people, think of a splint being like an ice skating rink, because what you want is well, you guys laugh at
You're
me.
like, you have the best.
You have
I mean,
all
you
the
do.
analogies.
No, I
love
it.
it.
But people
love
get it.
I love it.
People,
No, I use
So,
the same
so if your
analogy.
neck is locked up, okay, you want to free one of those three legs of your stool, okay? So what you're going to do is you're going to get on an ice skating rink. You're not going to lock into your occlusion. So a lot of times people do is they will get their skates stuck in the ice, okay, and they're going to get stuck in their occlusion. So the purpose of this is for a totally different perspective, but the more you lock into your bite,
Right.
that can potentially cause TMD problems, which will put more compression on the joint. We want your mandible to move freely from side to side, so it'll free up your neck. So then what we have to do is like Lori said, we have to stabilize the things underneath your head and neck, your shoulders, your torso, your thoracoabdominals, all that stuff to kind of get things. So you're not putting all that stress on your neck, because now we freed up your bite. You're not using your bite to stabilize your neck. We got to use the under what your body was intended to use for underneath. So
Sorry guys, I changed the battery, but it is still not pulling up. So I have no clue what's going on there, and I don't want to end the stream and then make everybody rejoin it. So if you guys have any other questions, kind of throw them out at us right now. Otherwise, I think we kind of hit it pretty hard. The neck influences the position of your jaw. You got to look at both. Any other
Or if there's
last
anything,
minute thoughts?
future things you want to talk about regarding this, I know we kind of talked about headaches, TMD. There's other purposes that we can kind of get in a whole nother, Dave alluded to, the floor meeting the floors. But we use oral appliances not just for TMD, we're using it for a sensory oral orthotic to help, I would call it dysautonomia, people that have dysautonomic issues. So that's another whole nother thing. But if there's interest in that, or if there's anything in general, feel free to comment or down the road, or if you shoot us an email on things that you guys want to talk about. I know we're talking about next month. Or what are we talking about next month? Is it vision? Maybe Steve?
I don't know.
Don't remember.
I think it was. I think we were going to talk about how to integrate PRI in the gym.
Is it a gym?
Yeah,
Okay.
like with,
So, there's a lot
Yeah.
of topics that we know we want to talk about, but if there's topics that you guys want to talk about, feel free, because this is for you. I mean, there's things that we could talk about till midnight if we really want. Well, seriously.
No, I know.
So it's just a matter of which, we want this to be informative for you, to keep this going for you. And if it helps you, that's what matters. I mean, we're not trying to treat you by any means, but we're just trying to give you some input or maybe some different perspectives on maybe look at things differently.
Can somebody speak to maxillary cants? Just wondering if you would build up one side of the splint to accommodate the cant.
You could, but again, if you look at the research, there's 67 to 72% of the people out there have a cranial torsion, and they may have a cant. You're kind of just chasing that. If you don't have the cranial bones in the right position, you don't have your neck in the right position. From a dental perspective, you're just looking at the teeth. So that would be my take. I mean, you can do that. It might temporarily help, but it may make you worse too at the end, because if you don't have the neck in the right position, you're trying to build up one side and the neck is in an awkward position. It may make things worse. So that's why when you start talking about torsions and you start talking about cants and stuff, that's a dental term, which is good. But I think from a dental perspective, I think dentists can treat it. But I think they also, if you look at a lot of that, there's a lot of terminology out there. There's orthognathic dentistry, there's orthopedic dentistry, there's all these different dentists. You want to be working with a dentist that looks at the whole body, not just from the one perspective, just looking at your head, from basically your cranium, and they're not looking at your neck down. There are dentists out there that look at the whole body, and sometimes they're looked upon differently because the dentists, I know, but they don't know any better, because that's what they're looking at. They're looking at the whole body, but the regular dentists kind of frown upon them because they're looking at things that may not be associated with dentistry. But there is an influence. I mean, tons of research out there, from as far as how the foot influences the dental occlusion. I mean, they're doing it in Europe and Italy, and they're doing it in all different places. But there is an influence on cants. But if you're just only looking at from a dental perspective, and you're not looking at the whole body, I could tell you have a cant of the pelvis, and you could have a cant of your shoulders, which is also influencing why you're having a cant of your bite. So it's just a matter of how you're going to line up all those lines to be in what we would call a neutral state.
All right.
Can we discuss your appliances as a topic for one of your?
Yeah, I think we could maybe do like a talk or something, not necessarily maybe a live stream.
Like a handout.
Yeah.
We actually have the handouts for that discuss what the difference is and why you'd use that.
One versus the other.
one
Yeah,
versus the
we could post it on to this when we put it live stream and whatnot.
just so those of you know, the question was made, can you guys discuss your appliances as a topic for one of your next presentations? And so we're just discussing them. It could be maybe a little bit different talk with the handout that we could attach.
And I guess what I would say too, when you say our appliances, it's not quote on our appliances. It's appliance that we've the Posture Restoration Institute kind of developed to kind of do it. It's not a Huruska Clinic appliance. It's guidelines to promote. Anybody can make that appliance. Any lab across the nation can make that appliance. It's just, it has different characteristics in that appliance for its intended purposes. It's going to have some canine guidance. It's going to have full occlusal contact. Some of them may not have canine guidance, as much canine guidance with the MMOO, but it's just to clarify that it's just guidelines. It's not a Huruska clinic appliance. So I just want to verify we're not making that appliance. Any dentist can make that appliance.
It's just based on the science from the Postural Restoration Institute. And if you're a physical therapist, you could go to the Cervical Revolution course. And PRI also offers an occlusal course that you could go to too.
All right, thanks guys for joining in. Next time we'll do better with battery. No clue, I changed it before. But this will hopefully get posted maybe the end of this week, beginning of next week. But if you guys have any other questions, feel free to send us a message, comment on here. And thanks for joining us. Have a good evening.
Goodbye.
Thank you.